Hello, and welcome to today's webinar, Health Reform and Medicaid, HCH Coverage Changes, the Current Status in D.C., and the Expansion Experience in Indiana. I'm Barbara DePietro. I'll be your moderator today for this webinar, which is presented by the National Healthcare for the Homeless Council. It's part of our spring virtual training, and this is with support from the Health Resources and Service Administrations and the Bureau of Primary Health Care. This session is being recorded, and the recording will be available as well as the slides. So for those who are looking to share this with others or who want to come back to it, please know that this will be available in a few days. This will be a 75-minute presentation, and we're having the last 15 minutes reserved for questions and answers. So if you'll notice, there's a chat box below the presentation slides for any questions or technical issues that you might have. If you type your question or your issue into that chat box during the presentation, we can provide you with some responses. As many questions as we possibly can get to, we'll answer at the end of the session. Any remaining questions will be logged, and we will try to do written responses afterwards. If you have technical issues and somehow aren't able to connect, you can try to call our office at 615-226-2292 for assistance. Also important to know, this session is accredited for one continuing medical education credit hour, and that's through Vanderbilt University Medical Center. If you need to claim the credit, please copy the information located on the CME Information Notes pod, which is at the right of the PowerPoint slides, and follow those instructions. The text-in code will only be available during this session. So that's the technical part. A little bit about today's discussion. We'll just talk really quickly about why health coverage is critical for people who are homeless, just a refresher there. And we'll talk about the recent proposals to change how healthcare is financed and delivered. A lot of health reform changes going on right now as we speak. But then the meat of our conversation, we'll talk about HIP 2.0, and that's how Indiana expanded its Medicaid program. And we can look at the operational aspects of note, and then how HIP 2.0 is impacting people who are homeless in Indiana. And we'll also, of course, talk about what proposals are in Congress before moving to questions and answers. So just as a refresher, most of us probably don't need to be reminded, but just to kind of get on the same page, when we talk about healthcare coverage, when we talk about Medicaid, when we talk about other types of insurance, we know that insurance specifically provides us a payment mechanism to access healthcare services. And as we know, the population that we're serving, people without homes, have got disproportionate levels of chronic illness, acute conditions and injuries, behavioral health conditions, communicable disease. And so from a health center perspective, we can do a fantastic job of managing that in an outpatient primary care setting, but there's a limitation to what we can do in that setting. And so having access to a broader range of comprehensive services like specialty care, hospitalizations, and surgeries really makes a difference in how well we can manage and treat healthcare conditions and how well we can get people on the path to good health and stabilization. We know also that for us as health centers, healthcare coverage and being able to have third-party billing stabilizes our finances. It increases the jobs and the capacity for the types of care and services we're able to offer, so allowing us to do broader expansions to then better meet the needs in our community. So again, this is the kind of thing that is a financial stability perspective for us, healthcare stability for our patients. And what we're starting to see, even though the Medicaid expansion broadly in expansion states has only been in effect for a few years now, we're starting to see real turning the curve on clinical outcomes. We're starting to hear both anecdotal information, but a little bit more we're seeing emerging data that shows that people are getting more stable as they're getting better health. They're able to move on to employment. They're able to reconnect with family and regain housing. So these are the kinds of things that are the outcomes, too, in a more broad sense of what we're trying to do and what some of the broader outcomes in health centers serving homeless populations that we're excited about. And so with that in mind, just want to introduce you to the speakers that we have today. I'm really excited to introduce Peggy Bailey. She's the director of the Health Integration Project at the Center on Budget and Policies Priorities. They do really great work doing safety net analysis and a lot of policy briefs. Peggy's got long-standing expertise in housing and Medicaid, so really glad to have her on today to talk about what's happening currently on health reform. And then we'll spend some time today talking with Renee Kugel, who is the Chief Operations Officer at Indiana Health Centers, and her colleagues Miranda Bueno and Clarence Walker, who are outreach and enrollment assistants and navigators out also in Indiana health centers, really trying to get people onto benefits and be able to also, everybody having that piece of health care. I've tried to squeeze all of our pictures onto this slide. That's me, Barbara, in the corner, and our speakers here. But I'm really excited to turn this over to Peggy so that she can take it away and talk about where are we now. And so with that, Peggy, I'll introduce you.
All right, thank you, Barbara. So just as to give myself a little clearance, know that things are changing as we speak. I am keeping my email open just in case something changes while we're on the phone. And obviously, especially since the bill just, the new bill, the American Health Care Act just came out on Monday. This is my first time presenting on it, so just bear with me if I stumble over some words. So what I'm going to do today, as Barbara said, is start with the, oh, whoops, I don't want to move too fast. I wasn't patient enough. Is start with where we are now and what's happening here in D.C., starting with reminding just a level set that the process of what may happen regarding Medicaid policy is a multi-step process. There's the legislative pieces that, as we've said, are happening right now, or at least part of which are happening right now, where Congress can change parts of the Affordable Care Act through what's known as the budget reconciliation process. That's what's happening now with the House starting and moving through legislation to repeal the Affordable Care Act and replace parts of it. It has to happen through this policy wonky term because that allows the Senate to only need 50 votes. For budget matters, there are special rules, and therefore the things can the budget reconciliation pieces are not subject to filibuster, and that's why they only need 51 votes. They don't have to override a filibuster, which requires 2/3 of vote in the Senate. But not everything can happen in the budget reconciliation process. As the name would infer, only things that apply to the budget can happen in that process, so only money things. There are pieces of the Affordable Care Act that are not considered budgetary items that have to pass through regular order legislation, which would require 60 votes. The budget pieces obviously are the biggest pieces. But there are, depending upon how that process works out, there are some things we're going to want to look for regular order legislation later in the year to make sure that we protect as much as we can. So there's the congressional piece. The other piece are the things that the Department of Health and Human Services federally can do through waivers that they approve, like in Indiana, and regulations that they can publish that help all of us understand the details of what it will take to implement Medicaid policy. So there are things, so HHS could do new regulations, they could rescind old regulations, but those are all things that happen outside of Congress. And I'm going to touch on both of these things, mostly in the congressional piece, focusing on budget reconciliation and what's happening right now, and then in the waiver policy, and that will pass it on to Indiana because Indiana gives us some big clues about what might get approved in the new administration. So then the first part of this slide explains some of the big things that are at stake when it comes to budget reconciliation in Congress. That is the potential repeal of the Medicaid expansion, altering the benefits that plans are required to cover, including Medicaid, and changing the Medicaid program as a whole from the entitlement program that it is today to what's on the table now is called a per capita cap, but I'll get into that on the next slide. So what is in the American Health Care Act? And as I said, so first It would end the Medicaid expansion. There was some confusion about this when the bill was first introduced, because what it does is this end is gradual and slow, and it starts in 2020 with a freeze on the new enrollees into Medicaid expansion and a reduction of the federal matching rate. As you probably remember, when the expansion started, the match rate that the feds gave states that expanded was 100%, dwindling down to 90% by 2020. Instead, the match rate that states will get for the expansion population will be whatever their regular match rate is, which is somewhere between 50% in states like New York, all the way up to, it fluctuates into the high 70s in West Virginia, Alabama, or Mississippi. Those states are usually the higher states with federal matching rates. So not necessarily so bad in those states, but still a decrease. We projected, as of yesterday, that this would result in a $253 billion cut to the Medicaid program, to the expansion, in the expansion piece over time. The next thing to look at is changing of the Medicaid program from the entitlement program that we have now, where people who are eligible, everyone gets it, to what has become known as a per capita cap program, which is capping the Medicaid spending based on the medical consumer price index plus 1 point. So basing it, so it's not a block grant would just give states a block of money for Medicaid and with no growth. The only redeeming factor of a per capita cap is that it at least grows a little bit, but that medical CPI rate is not the same as what healthcare cost spending grows at normally. So you would still start to see caps over, or cuts over time, and we project that those cuts over time would result in $116 billion within the Medicaid program. So that, which you'll see on the next slide, totals $370 billion over the next 10 years of cuts to the Medicaid program. The other there are several challenges to per capita cap, which we have materials on our website about, but the biggest one is that there's no adjustment for epidemics or bad economic times. So, for example, in the last recession, the federal government increased the match rate that they gave states for Medicaid, so that the federal government took on more of the cost of the Medicaid program, knowing that more people would likely be enrolled. That kind of thing won't happen in a per capita cap instance at the way it has in the past. The last piece is reducing uncovered benefits. The current bill being debated rescinds the essential health benefits, which for us, your primary care obviously is something that'll be covered, but behavioral health services are and maternity care are some of the things that would be at stake if the essential health benefits were rolled back. And just to bring this point home a little bit more is on the cuts piece. This helps you see. And I think it's particularly important for states that are non-expansion states, so that you can see what the cuts would be. In the dark red is the cuts that nationally that would be caused due to cuts to the Medicaid expansion group. The light pink is what cuts a per capita cap would do to all Medicaid enrollees. So you can see where there's not as much lost if you didn't expand. There's definitely still Medicaid cuts on the table. So what's happening right now? The ACA Repeal bill gets split between two committees in the House, the House Ways and Means Committee because of the tax components, and the House Energy and Commerce Committee because of the Medicaid components. Debate on the bill in both committees started today at 10:30. Democrats are, Democrats and Republicans are offering amendments to the AHCA, and so debate on those bills is dragging out, and we're not sure right now when they're going to end, if they'll even. I have on here March 8th and 9th, but once the debate got started, we could see that that's probably going to that might extend further. The target is for floor action to take place next week, so very fast. And it is unclear right now whether they have the votes for it to pass on the floor. Democrats, conservatives, and some moderates have issues. The conservatives are worried about how much the bill costs overall, and the fact that there are some provisions of the ACA that are maintained. Moderates are concerned mostly about Medicaid and the cuts to Medicaid, and the Democrats are obviously concerned about ACA repeal altogether. If the House passes it next week, the Senate is expected to take it up immediately the last week of March, but again, it is unclear whether they have the votes to pass it in the Senate. You may have seen that there's a block of again, the debate splits in the same ways, where there are conservatives that are upset, moderates that are upset, and the Democrats overall are not happy. So so anyway, that's all to say that everything is unclear. Now, moving on to the HHS policy changes. Much of the ACA and Medicaid policy, for that matter, is at the discretion of the Department of Health and Human Services, and more specifically the Centers for Medicare and Medicaid Services. Regulatory authority is one way, as I said before, that they can make change, but this takes a lot of time. There are rules there about how regulations can change, and so it usually takes months, if not a few years, for regulations to change. The next is waiver authority, and this is faster because states submit waivers, and usually, I mean, not that it can't take years or a year or more for a waiver to get authorized, but that's solely at CMS and the state's discretion depending upon how the negotiations go. But it's much faster than the regulatory process usually. This is where Indiana's ACA implementation fits, because the way that Indiana implemented the program that you're going to hear more about was through a Medicaid 1115 waiver. And just for those to remember, the Medicaid waivers usually have numbers attached to them. Those numbers do not mean anything much, except for that's the section of the statute that waiver authority appears in. That's all that Medicaid 1115 means. But that's what Indiana used. This is also important because, as you likely know, the new leadership at CMS and probably and the leadership specifically to the Medicaid program will both be coming from Indiana and had leadership roles in creating Indiana's waiver. And they've come to DC with the goal of increasing state flexibility in the programs. Now, one thing that we need to watch for, and that you'll hear a little bit about as we talk about Indiana, is sometimes flexibility means things like being able to charge people more for the care that they're given, being able to drug test people in order to either deny or allow them to have benefits if they pass their drug test. Adding work requirements to Medicaid is also something that's been on the table, and other enrollment cap type things to do, like Medicaid expansion restrictions. So this would be, rather than implementing all of the eligible folks into Medicaid expansion, creating subcategories of folks who are allowed to be on Medicaid, say, which can work. Utah submitted a waiver to only expand for homeless populations, for example, rather than all of the people up to 138% of the federal poverty level that the Affordable Care Act allows to be part of Medicaid expansion. So just a little bit on Healthy Indiana to just give some background. Healthy Indiana program is a little complicated, so you may hear me talk a little bit about it, and then Renee too, so that we can be a little repetitive in some of the, to help all of you understand what's in HIP 2.0. So HIP 2.0 is being implemented right now, but Indiana recently submitted a request to extend it and add some things like and one of the like substance use treatment services to the plan. So that's under consideration at CMS right now. The initial demonstration so far expanded Medicaid to about 400,000 people. 60% of those people were previously underinsured, and created two programs, HIP Plus and HIP Basic. All of the Indiana health plan enrollees have incomes up to 138% of the federal poverty level. They have what Indiana calls power accounts, which are health savings accounts that help them pay the deductibles. Their non-emergency medical transportation is waived, is something that's not provided as a part of the program. And there is a pilot to test work requirements and how work requirements might work for the population among a small number of the enrollees. So the difference between HIP Basic and HIP Plus is for people who pay premiums. The premiums range for an individual from $1 to $27. For a family, Renee has this in her slide, it can go a little bit higher. There are copays for non-emergency use of the ER to try to limit that. But missed premiums means you get disenrolled from the program. For those with incomes below at 100% of federal poverty and below, you get enrolled in HIP Basic. For those between 101 and 138, you get bumped out for a short period of time. HIP Basic has fewer benefits that are allowed, but it does have co-payments that are provided with services, and you'll hear more about that in Renee's presentation about how that works. So now I am going to pass it on to Renee.
Thanks, Peggy. Yes, little did we know when we scheduled this webinar that today would be the day that would start a lot of decision making. So it was a little serendipitous that we would have this webinar today. But as Peggy mentioned, I will talk specifically a little bit about the HIP 2.0 program, both Basic and Plus, and then my colleagues Miranda and Clarence, they're actually Indiana we outreach and enrollment specialists, or as we call them in Indiana, navigators. They're going to talk a little bit, they're the ones really in the trenches getting these folks signed up for the program. Clarence specifically works in one of our northern Indiana clinics in South Bend, Indiana for one of our clinics called Project Homecoming, which specifically caters to the homeless population of South Bend and those surrounding communities. So when I get done kind of going through the slides, I think they're really what they can talk about, especially as it pertains to some success stories of the program, and you all will hear how really this Medicaid expansion program for Indiana has made a significant and powerful impact on our communities. So with that being said, I'll progress. You know, Indiana is behind on a lot of things, but this is one of the areas that, in my opinion, we've done quite well. And as Peggy mentioned, we have already submitted an extension, or a request to extend the program. So what's currently in place was approved January 27th of 2015. And the extension, it would go into effect if it's approved in February of 2018. And since Peggy just talked about it, I'll add to that. Part of, you know, one of the incentives for Medicaid to expand this program was for Hoosiers to kind of, part of it was for them to understand what it means to have insurance and to have, quote, skin in the game, for lack of a better term. And one of the requirements put in for the extension is a suggestion was that over 50% of Hoosiers who are currently enrolled in the HIP program, both basic and both the programs, are smokers. And as we all know, smoking clearly costs the country millions and millions of dollars because of the consequences to that. So one of the conditions put in the extension to the new program is that if you are somebody who is in HIP 2.0 basic or plus and you smoke, the first year on the program, you will, be referred to counseling and to all kinds of services to hopefully get members in a place where they can quit. And then at the end of that year, if they've not been successful, they'll actually end up paying more for premiums, and there'll be a penalty to that if they continue to smoke. So the good news is we're putting things in place here in Indiana to assist with people to quit smoking. So hopefully we'll be successful in that way. But HIP 2.0 qualification standards currently they cover adults somewhere between the ages of 19 to 64, and prior to this program, that was the largest age group that we would see uninsured, unless you were a pregnant mom here in Indiana that might qualify for pregnancy Medicaid. So that, now those people in that age group have this safety net. Income levels up to 138.5% of the federal poverty level, and you can't be in a Medicaid or another Medicaid type program. So clearly if you already have, let's say, package B for a pregnancy, you're not going to qualify for HIP 2.0 until maybe you get off of that plan. And then no enrollment cap for that. So there's two different levels of coverage. As Barbara mentioned, there's the HIP 2.0 basic program, which only covers medical, and it's about a $4 copay per visit. Clearly, a lot of these folks are still coming, or that are coming to a federally qualified healthcare center. We will, we still see them even if they're unable to pay that copay, but we will bill them nonetheless. The HIP 2.0 Plus is the one that contains the power account, and it's really a very superior product in that it covers medical, dental, and vision. And I will add, the medical piece also contains behavioral health. And I know for Indiana Health Centers, that's one of those things that we integrate in almost every health center that we have. So for these folks coming in with the HIP 2.0, they're getting all their needs covered when they come and obtain services from us. And then there's no copay. There's no copay with that. The power account contributions, as you can see on this slide, one of I won't read you all the numbers, everybody can see that, but one of the things that Indiana has, one of the managed care organizations, one of the, how do I want to say it, the priorities is for them to have these members understand, you're paying maybe $1 premium a month. However, you're getting $500 worth of services in that month because you've gone to the dentist and you've gone to your primary care physician and you've done all of these things. So they do receive an EOB every month from these managed care organizations, explaining to them, just as anyone else who has private insurance, what it costs for this appointment, what you paid and what was paid for you for that coverage. Consequently, some of what the managed care organizations would like for, well, you know what, I'll get into that on another slide because I've got some of that information on there. What happens with a patient if they fail to, consequences of not making a power account contribution? So if you're one of those lucky people that are on the HIP 2.0 plus, but you forget to pay, you are moved back into the HIP basic program. If the client is above 100% of the federal poverty guideline, they are removed from HIP 2.0 and are ineligible for 6 months. So there is a penalty for that. This slide, especially for community health centers, is very significant for us that serve this type of population. I've been working in federally qualified healthcare centers since 1994, and honestly, I never thought thought in my lifetime I would see a payer mix impact of this magnitude. So as you can see, in 2014, this is just for Indiana Health Center, so these are statistics just for our organization. Back in 2014, our medical population, we had about 20.5% of our patients were self-pay. So in just 2 years' time, with the induction of HIP 2.0 and HIP in the power account, our payer mix has been reduced to 12%. Dental is down to 32% from 44%, and behavioral health is down from 27% to 9.8%. So those of you that are on this call that work in community health centers, I think you can say along with myself that I never really thought in my lifetime I'd see some of these payer mixes shift in this regard. So it's extremely important because, you know, one of the things that many of you know, that when you're a self-pay patient, it's not just about going and seeing your primary care provider. It's you see your primary care provider and they indicate that you need to go to a specialist. Well, all of a sudden you may need to go see a cardiologist. And even though they may see you on a sliding fee scale, that appointment still may be hundreds of dollars. And we all know what the likelihood of those patients showing up for that is going to be. So, you know, this has not only impacted us as community health centers, but, you know, now we are able to really refer these people out to other services they never would have been able to afford before. The power account cards, this is where I was speaking to previously. This is one of those areas that the managed care organizations really want these members to understand really what they're getting for these low premiums. However, as you might imagine, there have been some challenges with that. The managed care organizations, or the MCEs is what we call them in Indiana, they don't all have the same website. So when these folks come in to register at our front desk, depending on what type of MCE what type of insurance they have, if they have Anthem, they have to log into one website. If they have MDYs, they have to do another site. So it has increased the workload for our clinic receptionists at the health centers. One of the other things that the managed care organizations, Indiana Health Centers was a pilot program where they had us install these credit card machines that we ran their power account cards through, so we could basically give these members a receipt at the end of their visit saying, you know, you paid $10 today for your visit, however, we provided you with $300 worth of service. But the MCEs don't fund these credit card machines, and they're about $500 for us to purchase. And quite frankly, when we did the pilot program, it wasn't accurate. So we since then, and since I developed these slides, there's all the managed care entities have come together along with some of the health centers in Indiana, IHC included, are trying to come up with a way to improve the workflow at the health centers, because this quite frankly was disastrous for us. And we piloted this in one of our large health centers where we have, on any given day, 9 clinic receptionists. Well, in some of our sites where we have 1, maybe 2 clinic receptionists, there's no way that we could manage that. So the good news is the managed care organizations heard our concerns. So we're still going to have to do something. We're just not quite sure what it's going to be. So again, from a workflow standpoint, that really increased for the health centers. And there's just a repetitive process between the health center, electronic health record, and the MC websites, because we were having to do dual processes, sometimes triple processes in trying to do that. That, again, the power accounts talk to the personal responsibility. The state wants to emphasize to the members what their costs are compared to the premiums that they're paying. So how do individuals prove they have paid their power accounts? Both our clinic receptionists and our outreach and enrollment staff can verify this with the Medicaid web interchange, which I'm sure most of you are familiar with. As you might guess, sometimes these members lose their cards, or maybe they're stolen, they've misplaced them. They have to really contact the managed care organizations immediately. But if they have some kind of identifying information, we should be able to look them up in the Medicaid web interchange. The outreach and enrollment staff are able to call on patients' behalf, but the patient must be present at the time of the call in order to get things adjusted with those power accounts. The application process, I think, especially to talk about the homeless population in particularly, there's a really large amount of, it requires a large amount of documents to provide your proof of income or lack thereof. And clearly, especially with the homeless population and their transient nature, this is frequently very, very challenging. It can also be a really lengthy process, and Miranda and Clarence might be able to speak to this a little bit more when I hand the call off to them. But if you have a family with multiple members, the visit can be really long trying to gather all that information. And the length of time for approval versus denial can also be lengthy. And then if just one field in the application isn't completed, you have to start the process all over again. And I know for the applications, if the field is missing, they can correct that and reapply. But if they've been denied for other reasons, there is an appeal process. But the outreach and enrollment navigators tell me that the appeal process is not very successful in most cases. So again, the homeless population, proof of income, the cost of the premiums. If they fail, excuse me, if they fail to pay the premiums, they'll be ineligible for the program for 6 months. So then we're back to the drawing table again for not having any type of coverage. And they can incur a $25 copay for an unnecessary emergency room visit. The good news is many organizations have found that, especially for the homeless population or other people that really can't pay the premiums, it's cheaper it's less expensive in the long run for these organizations to pay, let's say, a $26 copay for someone. That costs an organization far less money than it does if these people go without that type of coverage. So many organizations clearly have done the math and said, you know what, we're going to pay this this $26, $27 copay because we'll reap the benefits from them having coverage, plus clearly the patients will. If the annual income is below 100% of the federal poverty level, the member will be moved into the basic plan, which of course only covers medical. And there is an exception. Members will never be removed from the plan if they are considered medically frail, they live in a domestic violence shelter, or they're living in a natural disaster area. So overall, again, the benefits clearly outweigh everything else, but you know, Medicaid contracting entities and family and social services, those MCEs don't really talk to each other. So again, this makes it more of a nightmare for our staff than it really does for the patients. Completing the paperwork, and I'll let Miranda and Clarence talk a little bit about presumptive eligibility challenges. But again, as I mentioned, the benefits outweigh everything because we're seeing more people than ever getting coverage for their medical, pharmaceutical, dental, and behavioral health care, and it's making a significant impact on the health of Hoosiers. So with that being said, I'm going to turn it over to Miranda and Clarence because they really do the important work out there in the field, and I'm going to let them share some success stories with you and you know, what's going well and then some challenges that they experience.
Good afternoon. This is Clarence Walker. As Renee said, I work at the Clinic for the Homeless Population in St. Joseph County here in South Bend, Indiana. I think one of the key things was when we started this out with the inception of the activation of ACA about 3.5 years ago, we had to really kind of develop our own program for this because we didn't have a blueprint for it. So what we did, one of the main things we had to do was to go out into the community, research all the places which service the homeless population, everything from the youth levels to the adults of full family services. And doing so, then we got to asking more questions from these various organizations, whether it be food kitchens, churches, places like the Center for the Homeless, Hope Ministries, a good variety of places, and some of the area youth organizations for youth which fall into that age group, whether it be centers for people who are getting their GEDs together, those who could benefit from this, and much of the homeless population, many people in the homeless population are actually attending a lot of those places, which provides the opportunity to talk to them, to educate them, as well as enroll them and inform them on what we do and what's available to them. But that networking is essential to the success of any program like this, and they just, you know, that's one of the major things that we did actually. Okay, so now another thing is that once we got, some of those places weren't as receptive to our coming there for a while because they were against whatever their political beliefs and all that. But after they started seeing results of it, the results of people hearing that, like sometimes you can't just go to the soup kitchen that's open at 6 o'clock in the morning. You have because everything doesn't open at 8 from 9 to 5 or 8 to 4. Some programs are in the evening. So an example being the Center for the Homeless here, which has a very large population here, services entire families and individuals. They have housing for them, educational places for them, life classes for them, and the like. We not lucked out, but through networking with them and volunteering over time, and it didn't take a long time for that. But I mean, professional partnerships had developed before that, so they're already in place for us to easily kind of move into areas, certain organizations or agencies once they knew what we were all about. You know, because sometimes in the evenings at Center for the Homeless, in order to get the entire staff and the entire all the residents there. They have a residents community meeting several times a month. And when they have that, it's like an hour and a half long, but they would give me 15 minutes to do my presentation, and I would go there with some slides that I had and a question and answer session and talk to people. And then so they were much more receptive to us, to us being there. And then by word of mouth, of course, in a population like that, you can go to, people start coming into the clinic more saying, you know, well, they'll say, you guys do this, you do that, I need to sign up for this, I need to sign up for that. One of the other things is that some of the, just to touch on this briefly, the success stories almost make you cry sometimes, because here you have some people who were in their 40s or 50s or whatever, they haven't had any medical attention since they were on Medicaid as children, you know, and of course with the age limit, Medicaid as children with their parents. And so now they have that available to them after they go through the process. After they go through the process of filling out the application and all the things that entail in that. And then now, because I'm not mentioning any names, but there was one example is a lady who, several different women who didn't know, they knew they had history in their family of certain forms of cancer, and then once we got through this, after this several weeks or several months process of them going from us to of course the education, the enrollment, and then the doctor's visits and the specials they need to do, they discovered they had some things were going on with their bodies that they needed to, perhaps sometimes should have gotten in check sooner, but were unable to do that because they couldn't afford it. That wasn't available to them. But some of them, you know, are doing, some of them aren't so, don't have such a happy turnout in the end because they're gone, but the majority of them that went into care, when looked into that, had they've got their health on track, and then they were able, some of them were able to like go to work. They don't do that because they were always in pain or their living situation wasn't correct for them to do that in, and get more of their life on track as far as health, as far as living situations and all that. Just another thing real quick is that I discovered many people who were coming from Department of Corrections and they were homeless for whatever reasons. A couple of guys had these hernias which were really, really bad while they were incarcerated. So they gave them like mild medications for that, but never could get them looked into like really seriously because some place facilities don't allow it or don't do it. But we're able to get a lot of that straightened out, and it went to work as a result of getting those things taken care of. They got jobs in some of the area factories in this community, and we're able to become contributing members to society in a very positive way because their health is in check, and we all know if you're feeling better, you're going to want to do things better, and you know, you're going to be more involved and you have the opportunity to do better.
Hello, and this is Miranda Bueno. To add on to that, there are, you know, several different things where we're able to go out to the community, and as Renee has mentioned, the coverage numbers have gone up a lot with that. Dental is a big one. I work at our health clinic on the west side of town of Western Avenue, and we have our dental clinic here. So homeless population, a lot of people come in for dental work, which we handle here. There's a lot of them would prefer for us to go to them opposed to them coming to us. It just makes them feel comfortable. That's in general. Presumptive eligibility is another topic that Renee wanted us to touch on. Presumptive eligibility is not as easy as people seem. The follow-through is very hard when you're homeless predominant because mailing changes. We have several locations that'll let them use their address for the homeless to get their mail. But if they transition out of location and they can't get their mail in time, they don't follow through with their letters. So we're back to square one with presumptive eligibility, especially in dire need where they need emergency care services. This is something that's a must, but it's a process for anyone, especially our homeless population. There are good and bad to it. The bad, again, is the addresses, but that's what we're here for. We're here for everyone with questions, as much as we can answer, help them apply, follow through with them, follow up with them, turn in paperwork. Paperwork is very difficult. Income-wise, not all homeless are unemployed. So with that, it's just a matter of making sure that they can keep their check stubs or however they get paid intact with them at all times. Because they do need to turn in their proof of income verification. It's a process for them as well as us, but we've come a long ways with the Affordable Care Act, with the Medicaid expansion, with HIP 2.0 and HIP Basic. And yes, the power accounts, good thing. You know, everybody, the locations that we have are able to pay their power account contributions and are willing to do it just so that they can get their coverage or their medical needs. They can pay up to 10 months in advance, you know, which is a plus for a lot of people. They have a $1 power account contribution. They can pay the $10. That covers them up for the 10 months, and they don't have to worry about falling out of the HIP 2.0 back into HIP Basic. The lockout period is 6 months, which is for the people who fall underneath that 101% to 138% of the federal poverty level. The lockout is 6 months to where they'll, you know, won't be able to apply for coverage. For anyone underneath the 101%, the 100% below, they'll go from HIP Plus to HIP Basic, and again, the coverage isn't as good, but they still get the necessities of what they need. It's just a plus benefit in all the ways around. Us going to these locations, to the parks in the summer, to the food banks, to the soup kitchens, like Clarence said, those are very plus because they're welcoming us into their world per se to have us apply them. But it is a struggle. We just do what we can and look forward to what's to come next.
One of the things, too, I'm going to reiterate again, is that the key here, one of the major keys is the importance of doing the trench work and getting out there and becoming partners with or friendly with a lot of these agencies and organizations, which this is a totally new thing for them, and not so new to all of us now because it's been here a couple of years, but it's still a new thing nationwide. And one of the things is, you know, getting out there and explaining it to them and getting them involved in it, which is the important thing is when they came to us, well, people are having problems paying these premiums, what can we do? And so they actually were the ones who came with the suggestions that, and maybe they can help out with it. And some of them have the funding for it. Some of it may be an agency that's not a faith-based agency, but they have a faith-based agency or a church or something who wants to come in and help with that. So then they make allowances for that. And that makes a tremendous impact on people falling between the cracks or the difference in getting the necessary treatment they need as opposed to getting the minimal part of it. So not just, one of the things important is to go to places like the GED classes for people in that population, or places like, for example, here we have in South Bend an organization called The Crossing, and it deals primarily with GEDs for a lot of people and for the general public, but a large segment of the population is homeless. And you have to talk to the directors, the counselors, the life coaches to get that kind of information and to get connected with those people, you know, because of confidentiality things, people actually, they come to you. One of the things that I've discovered is that while we're outside of the office during the outreach, education, enrollment process, you still have to stay at the office, be around the office, or have people have access to you, or everything from reference cards to that where you can contact them when you're not there so you don't lose them because of that. Because again, with the homeless population, we're dealing with a very transient population. But the amount I'm still overwhelmed many times at the amount of people who continuously come in and ask for questions, follow follow-up. I can't say that enough times, follow-up with certain people, because some people are not going to they'll get the information, you enroll them, and then they don't necessarily follow up, or they have a time frame to respond to certain questions or things from the FSSA, which is in Indiana, which is Family and Social Services Administration, which fortunate for me, they are fortunate for me or us, they're at the clinic for the homeless, Project Homecoming in South Bend. It's like right across the street from us, as are some of the other social service agencies which service our population. They're within a 4 or 5 block radius, so we can either walk to them or they can send people to us, and it's not so much of a transportation population as in some of the larger cities where it makes it more difficult to get to them or even be reached by them. Another thing too is that I can be referred. Many people are referred to us from the doctors in our organizations when we got them involved in, where they know that this person, for whatever reason, if this person needs this, doesn't have insurance, we can, while they're still in the office, we can actually talk to them, and the majority of them will fill out the application, get the education they need behind it, explain it to them, and they go away feeling better about what's going on with them in their with their health situation.
This is Miranda again. Our payments if there are any questions regarding the payment, how to make the power account contribution. Again, opposed to even with the homeless who are unemployed as well as the ones who are employed, every MCE has a designated location, or MCO has a designated location. 9 times out of 10, it's a Walmart, where they can walk into a Walmart with their bill and pay their contribution anywhere from $1 all the way up to $27, whatever their contribution is every month. So not only can they pay it over the phone, online, they can pay it at, like I said, their designated location, or an organization can pay it on their behalf, which is a very big plus. I mean, to just be able to walk into a Walmart and know that you're going to pay your insurance and you don't have to worry about the struggles, or did it get there, did it go through? You know that you're getting your receipt and you know that it's being paid directly to where it needs to be paid. But Clarence is right. Education is the key, and just being there whenever they have a question when it's time for their renewal. We try to empower them to do things on their own, but it's still hard. So we still do a lot of follow-up, just in general, reading their letters, telling them exactly what they need to turn in. The letters from the Family and Social Service Administration sometimes are very difficult to understand. So they do come to us just to make sure, for clarification. And where Clarence is at, Project Homecoming Clinic, is right downtown. So it's a wonderful location. Like he said, that's not far from a lot of our homeless shelters, soup kitchens and things like that. So he's right in there in the mix with them. You can walk outside the door, and if somebody has a question, they're there to help, Clarence or myself, whoever's there to help, and that's what we do.
And I was going to say, sometimes we're a little bit hesitant. People who do the work that we all do, my constituents I'm speaking to now, that we do, especially with the homeless population. Some of the organizations you go to, you might think they might be a little hesitant at first as to what you're going to be doing and that kind of thing. But once you educate the staff on it, and then it's not that we were just going there giving speeches. We're going there when people are eating their breakfast or their lunch or their dinner, or having adult life classes, with getting your life back on track at different facilities. And they allow us we set up tables. We have the information that they need. It's sort of on an individual basis. We have our laptop set up, and sometimes it's in churches, church basements, or at soup kitchens over in the corner where things are confidential. They'll set up our laptops, and we can actually do the actual enrollment right there on the spot. As Miranda said, sometimes it takes place in soup kitchens, in church halls, in the park, summer events out in the park, in the park bench, a lot of community activities like that. Or it's just it's incredible the opportunities that you can have to enroll this population successfully and get them on the right track. And since all those organizations we're all on the same boat when it comes to trying to make it a better living situation and for the homeless population, this just falls right into place with it. So then you'll find them asking you, hey, we're having this or having that coming up. You want to come set up a table there so we can do different things like that. And it makes the job much more fulfilling and much more interesting. And besides that, we're doing what we're supposed to by helping people get their lives back on track health-wise. So that's whether through dental, vision, medical, through mental health. So it's a really, really good thing.
Renee?
I think that's it on our end, so I'll turn it back over.
No, thank you so much. That is a lot of information, both from Peggy, Renee, Miranda, Clarence, just in like all the things that are going on. And so a couple of questions have rolled in, and I think that let's have more of a conversation in our last 15 minutes. So I want to take some of the context of what is happening in Indiana. And Peggy, I'll ask this of you. You had mentioned that the new CMS director that's coming in is coming from Indiana. Do we have a sense that the direction that Indiana has gone, that Renee and Miranda and Clarence have described, do we have a sense that that is the direction that CMS might be going next to model Medicaid programs? Or how do we, to the extent the information that we have right now, how do we rectify what's happening right now with the bill that at least is initial offering in Congress, and what's happened in Indiana, given the new leadership? How would you project with your crystal ball, what would that look like?
So what I think is important to do is kind of separate this conversation in Indiana with what's happening in Congress right now. So when it comes to the waiver authority that CMS has, let's see, and think of them as sort of distinct but related things, right? So that when it comes to the bill that's moving through and just the repeal process overall that's moving through Congress right now, there are delays in when per capita cap would happen. There is tailing off and the ending of the Medicaid expansion, but that's not until 2020. So the assumption is that we would operate largely the Medicaid program for the next couple of years, at least as it stands right now for the most part. So that's where the waiver authority comes in, and states asking for waivers that at least in this short time frame. And it is unclear exactly what would happen in this middle ground if things move forward the way they are, it is not certain that what is moving through Congress, and actually it's quite the opposite. There's a lot of as I mentioned at the beginning, a lot of opposition to particularly the Medicaid part of what's moving through right now. That said, we would still have this time period where where we would have to see what the administration might do. That said, what we can take from the incoming CMS director and the person who's likely going to be, or who is talked about as being the head of Medicaid, is that particularly with Seema Verma, who's going to be coming in as the CMS director, not only did she do work in Indiana, but she did work in several states that expanded Medicaid and did it through using some of the mechanisms that Indiana has used. What we can take from this, there were other things in their proposal. What we can take from this is some of the things that were in their proposals that the Obama administration did not allow, like in Indiana, having the work requirement piece just be a pilot rather than being larger to the program, might get approved now that the leadership has changed. So what we can take from Indiana is thinking about things like the cost sharing, the work requirements, things like that. It doesn't have to necessarily be exactly the way Indiana do it, but what we can say is because these are the people that worked on Indiana's proposal, they like these things and would approve states who are doing more of these things than what we saw under the Obama administration.
Got it. Okay. Because Indiana, even though they did it under a waiver and they're doing some different things that other states just aren't doing, so they're kind of the first to really implement like a two-tiered system with a lot of this, the copays or the premiums, they still, though, would be subject to the caps, and so it's still, as an expansion state, under the current provisions of the bill that's currently being considered, they would still be seeing a decrease in FMAP and still be subject to the caps eventually, correct?
Yeah, all states would be subject to the caps eventually if that bill passed, whether it's expansion or non-expansion states.
Got it. Thank you. We had another question come in that I'll pivot back to Renee. Can you discuss the impact that all of this has had on administrative clinical staff when patients are disenrolled due to failure to pay premiums into the Power accounts? For example, have you needed to devote administrative time to reminding patients to make their payments? What does this look like for navigators to help people continually reapply after the 6-month period? It was just noted that it seems like that would be a significant impact on patient care, particularly if they were suspended from coverage during that period of time. So curious how our Indiana panel will respond to that.
Well, I can tell you it's honestly no different than when people have traditional Medicaid, because it happens all the time. You know, people will think they have some kind of coverage, they show up for their appointment, we run their eligibility, and they're no longer eligible for one reason or another. So whether it's HIP or some other type of coverage, our front office staff, our admin staff are just used to dealing with that on a daily basis. So we haven't really noticed that particular issue causing more or less of a disruption at, the check-in area. When I talked a little bit about the Power account cards, they're like a debit card, and doing that was disastrous. That was really, and we pretty much told the state there's absolutely no way that we can manage with the way they had piloted the program, running those cards and going in and out of all the managed care organization websites and putting in information, that there was just no way that we could do that. I'll let Miranda and Clarence answer, what they do to help people get re-enrolled, or if they track these people, and what they do on their end.
Well, on our end, one of the things that we have available to us, tools we do have available to us here in Indiana, is that we can call the FSSA here, which is the Family and Social Services Administration, who handles all the Medicaid, the food stamps, and Medicare here in the state of Indiana. We can call specific numbers to them, and we can find out, because a lot of times what a client tells you and what is factual can be two different things, or they're already confused by it in the first place. We can get the exact information we need from them and find out what the problem really is, and then we end up either re-enrolling them or taking them through the process again, which again is still benefiting the client, because they have the opportunity to get back on track with the health issues that they have, and we can also educate them even more on, maybe you shouldn't do this because this is what caused this problem in the first place, or those kinds of things. It's more of a re-enrollment and re-education.
Yeah, and with that, 9 times out of 10, it's either more so of misdocumentation, that they do not follow through with turning in their documentation. So if we can get in contact with someone, when we get in contact with someone at the FSSA, it's more of they have a grace period of anywhere from 10 to 15 days to get those turned in. And if they don't, like Clarence said, we just reapply them, and it works out for the best, because if they come into their appointment and we see that they do not have Medicaid, HIP, any type of medical insurance, they will be sent to one of us or our intake specialist if we're unavailable, and we will reapply them.
Got it. So one question I have as a follow-up in the power accounts, and really interested in this because the power accounts is the name of the health savings account, essentially. And because health savings accounts are a piece of what is kind of in the legislation now in Congress, not so much for Medicaid, but for private plans. But I'm really curious, how is it that your clients who experience homelessness are using their power accounts? Are they using them? Are they engaged in the goals of a health savings account being that people are more mindful, that they're more likely to use services more wisely because they're spending quote unquote their own money and being a more judicious user of services? How do you see those goals with the power accounts with your homeless patients?
This is Miranda, and I see that they do come in more. They use their power account as needed. They're more in tune to their medical needs, whether it's dental, like I've mentioned before, whether it's health or the mental health. We have seen a big turnaround. I have seen it in the dental part of it. Clarence has seen it in the health part of it, and they do take advantage of it. The power account contribution is their money. Their money is set in there, and there's a certain amount that's deposited into that card for the year. But if there's any need after that money, it's all free. So medications are included, all of that, and they use it to where it needs to. You see them coming in for their regular follow-ups. If there's a problem, they have any health issue, they come in to see a physician, which is a plus. So hopefully that answered your question.
No, I'm just thinking through then. One of the things I also was interested in was you had mentioned that with the premiums, or with the premiums in particular, am I remembering correctly that you said that sometimes there are other service providers that will help people pay those premiums? Is that right?
That's correct. There are, like as we said, nice churches or church organizations, different social agencies here throughout our area, which will assist them with that. Of course, they have to bring in the letter that shows how much it is. Not only that, they'll use, for example, one of the larger centers here for the homeless population in our city of South Bend, Indiana, is that it's called Hope Ministries. Now, I know this. I've seen it in action. Well, once they talk to their life coaches or their counselors, and they give them the information they need on the letter, which is the company, the healthcare provider company, whichever one it is, has that and has the account number and all that. Then they have specific debit cards that they created, that they have through their organization, that they'll call in with the client there and beside them, and they walk them in through it. So it's not a process where they just get the information and do it on their own. They make sure that their client is there, that the client is there to see what it takes to do that, and they actually make them, they kind of lead them to it or help them along in the process of doing it. It's about a 10-minute process, sometimes less than that. But it works out pretty good because, again, you're educating people on it, and they have that involvement with it.
And so, and I'm just fascinated by how all of this works. And so the process that you describe in Indiana seems like it might work really well. And what you're telling us is that people are using their power accounts, that they're able to leverage these relationships with service providers to help with premiums, to engage in services. So that would work, I think, for many of our patients. What about our more vulnerable patients who have got a lot more vulnerabilities, like more serious mental illness or have got more serious disabilities? Do you see that it's harder for our more vulnerable or fragile clients to engage in these kinds of initiatives than more of your higher functioning clients? I think
in that situation like that, which I see, sometimes you go through periods where you see that a lot. So one of the things is they are fragile with the mental health situation or health issues. It requires a little bit more extra patience as far as directing them. And sometimes I know we're not a babysitting organization, but sometimes we have to go do that. That's when the social worker type situation occurs, where you have to be more patient with them. Now we got to do it this way. This is the way this is done. The patience with it is really important, because that vulnerable population is just going to fall through like they always have, if someone doesn't take the time in some form or another. And it may involve with you getting in contact with organizations that they're affiliated with. In the majority of the cases, they are. They're affiliated with the Center for the Homeless. They might. I said, would you ask your life coach or your counselor to call me and give them my card with the name on it, or whatever, or they'll give you permission to talk to them, or you'll call them right there with them in the office, and you kind of make that partnership where you can better serve that client, because sometimes people need that extra somebody behind them in that way.
And a plus with our organization here with Indiana Health Centers is we also have ways, we give them bus passes if they need, so that they can get to these appointments. So that's a plus. If they have an appointment here with our mental health specialist or one of our physicians, they can come, we'll give them a bus pass at the time or the reminder, so that they can get to their appointments. So that also helps in many, many, many ways for those who are less fortunate, and, you know, can make sure that they get to their appointment, following through with them, or even meeting them, you know, going to the location where they're at and saying, hey, remind them that their appointment is set here. But it's coming, and it's coming slowly but surely, where they're getting to where they need to on their own.
Thank you so much. I think that's a great note to end on, in terms of the hopefulness, the assistance that people are getting, and piecing this together to make it work. Really appreciate your contributions. Peggy, Renee, Clarence, and Miranda, thank you so much for sharing your expertise and what you're seeing on the ground, what we're seeing happening in Congress. There's a lot going on. I feel like there's so much more we could talk about, and we're actually past time. So at this point, I just want to thank everybody for coming this afternoon to join our webinar. A link of this will be, and the PowerPoint slides will be available on our website at the conclusion of our spring training, so later in the month. As a reminder, if you want to claim the CME credit, text in the provided code within 24 hours of the session that's in the box there to the right of the slides. And at the close of this webinar, there's a survey to evaluate us. So please complete that, so that we can better understand the training that you'd like to receive, and more opportunities that we can create for you in the future. So at this point, I would just like to say thanks again for coming. We will have more of these events in the future. There's so much more to talk about. Really appreciate your time. Thanks for coming, and at this point, we'll close out the webinar.